So I think we now will begin with a panel of speakers, and Mark will also join us in the panel to talk. If you do have questions about, what is available to not just men with prostate cancer, but all manner of urological concerns, and if you want to know more about how this centre works and what is available here, Mark is able to answer that for you. But if I could invite all of our speakers up to perhaps, we might just drag a few chairs or perhaps join us up the front so that you can direct some of your questions to whomever it is that you're wanting some more information. Please.
The prostate cancer that doesn't have an elevated PSA is presumably more anaplastic and therefore more dangerous cancer. How do you monitor then, considering that one of the mainstays of the monitoring post-treatment is actually your PSA?
So the question was prostate cancers that don't produce PSA and are potentially quite aggressive cancers. How do you monitor the person's survivorship or their progression if the PSA has not been a reliable indicator in the first place?
I mean, there isn't much else we can do. We do PSA tests. Typically, if it's 0, it's useful because they still make some PSA. We can use imaging as we need to if you have suspicion. Also, you get a lot of idea about your pathology. So you could have a significant cancer, but if it's a small volume, organ confined, there's a better chance they do better, but they are difficult to monitor. Even with the modern technique, with the PSMA PET, a lot of these cancers don't express the PSMA receptor either. So it would be very hard to monitor them. But they things, if you do your PSA test, if you have suspicion, you can use bone scans and CT scans. We're looking for metastatic disease. But yeah, they're not easy. But generally their PSA does go up, even though not as much as you would expect. Still has a role, but it's difficult.
Any other questions?
The question I was trying to ask was, my urologist will write to me and tell these cases, and I expect him to do that. In the follow-up, I like to see him. Thanks, Jay, I saw him such a day. My next review in 6 months' time is doing well. I would like you to do this and this and this. And I have sometimes actually they give them a slip. So what I'm trying to tell is actually Homi is my boss who I rely on. We will look after the complication part, but we are still dependent on your guidance. That's what I was trying to base, because it's very important. We are GPs only, we are not specialists. So
of course,
the specialist is very good. Those who write to me regularly, I got a lot of prostate cancer patients there. Very useful letter. So he tells me, do this, do this, do this. I'll see him in about 6 months' time. Unless you see this one there, let me know.
Yeah, of course.
Very handy.
It's about how you interact with your GP.
That's what I was just trying.
But we try to own the complication. I mean, if we do it, we will look after them till they are better.
The side effects and all that, yes, we do have to watch that one and get their health there. Yeah. The patients on Xtandi, for example, their PSA level is highly unreliable.
So, I mean, that's castrate-resistant prostate cancer. It's combination of us and the medical oncologist, but these are complicated patients. They need to be seen often. The side effect needs to be monitored. So I don't expect them to go to general practice. These are end-stage disease. There are newer drugs coming. A lot of these patients will go on trials. If there is an Xtandi fails, even when we put them on abiraterone, you still have to monitor the potassium, you still have to give them the steroid. So I think that's getting a little bit complicated. Even as urologists, we don't have huge experience with them. I do look after them, but not everybody does. So medical oncologists, urologists, I don't think that's fair to ask GP to monitor the side effects. Yeah. It's good.
It's not what's the side effects there?
Or monitor the drug.
She mentioned that these people are depressed, they have to be looked after and talked to. Number 2, they have got a lot of side effects there. They've got all this pain and can't walk, very painful, many things there. GP has a very important role in those patients.
Of course, yeah, but I mean, it's as part of the team. I think this patient needs to be involved with everybody, really. Psychologists, exercise physiologists, medical oncologists, etc. So that's end of the game. So The median survival is like 18 months in that scenario. So, Jane.
Other question? Yeah, Jane.
I've got a question. I mean, so you've got a patient with prostate cancer, and the treatment options are active surveillance, surgery, or radiation.
Yeah.
I gather external beam radiation. I'm just trying to work out the place of brachytherapy.
So I used to say brachytherapy is for somebody who doesn't need treatment.
Yeah.
That's what I used to say. Brachytherapy has gone out of favor. Very small proportion are treated. Generally it was for low risk disease, so we don't treat those patients. So now it has a role for a small volume. I'm not a radiation oncologist, but it has a role for a small volume intermediate risk disease, and you can give it with combination of external beam. So it has a role. But it's in the olden days when it came, it was the things like, okay, no side effects, no problem, but a lot of them recur. So that's obviously it was too good to be true. Now they use it extremely selectively. They also use focal brachytherapy now. So based on MRI scan, you have a small volume cancer, you assume there is no cancer elsewhere, and you go and do brachytherapy only for the lesion. That's just crazy.
Like a lumpectomy.
Yeah, that's crazy. Okay, but the people do it. But brachytherapy is really gone out of fashion. I think Peter Mac does maybe 10 a year. So it's very, very much gone out of fashion. And when we looked at the data for all the treatment of prostate cancer, brachytherapy has really gone down. 10 years ago, very different story. Things have changed. And also when there is a high risk of bladder cancer with brachytherapy, because very high dose near the bladder. And also salvage of brachytherapy is very hard. That's the other thing.
Yes.
Two questions. The patients where you choose to repeat the PSA and the low risk patient, how soon after would you repeat the PSA? What's the period of time?
So the question is, in a patient in whom you're going to repeat the PSA, how soon after would you repeat the PSA? And it's generally 1 to 3 months, is what's written into the guideline.
So I agree. The half-life of PSA is about 5 weeks. So if somebody comes in, I see a PSA, I don't trust it. Let's say you send a patient who had a PSA of 0.5, now comes with PSA of 3. I generally say cancer doesn't happen this fast and this quick. You've been doing PSA every 6 months. Now all of a sudden it's gone up. I usually reassure them repeating in 6 weeks. Generally comes down. So 6 weeks is for the one that really crazy numbers you get. I would wait, treat the infection if there is, and repeat it. But if you're monitoring it, for cancer point of view, I think 3 to 6 months depending on your scenario.
What's the role of free PSA and a Freetototal PSA? I've got a couple of patients who seem very fixated on the free PSA and all that. So what is the role of?
What is the question is, what is the role of the Freetototal PSA?
So that's back a few years ago when we only had PSA, when we didn't have the MRI, the biopsy techniques were a bit more rudimentary, PSA played a very significant role. So we came up with all these differential variation of PSA. We talked about PSA velocity, doubling time, free total ratio, and so it does provide some guide. The idea is the prostate cancer has a lower total ratio if there is a lot of significant prostate cancer to do with the binding of the PSA. There are calcarein molecules, and the variation within PSA will suggest if your free total ratio is lower, the risk of cancer is higher. So if it's getting less than 10%, that alone does justify further investigation, even if your total PSA is normal. So it does have a role. I do use it. It's not everything, but it does help to sometimes, because you have patients with a very big prostate with a high PSA. So your baseline PSA is like 8. So it would be very hard to monitor this patient. But if their free total is lower, for example, and they've had a negative biopsy, I would use that information to say, okay, look, there is probably something here. So we investigate them a bit more, maybe more extensive biopsy, maybe early MRI use. So it is a very useful value. But there is that range of kind of 15 to 20%, that is the intermediate. That then becomes quite difficult. Then it loses its value. But I've certainly seen many patients with a normal PSA, very low free total ratio, and we found bad cancers. So it does have a role. It's useful.
Is there any value in taking comfort from an index PSA in the mid-40s below the median for the age?
Absolutely.
Enough to say don't ever do it?
Yeah, so there is good data. If you do a first PSA at 40 and it's less than 1, you can delay it for 5 years. So it's good data. Dutch data supports that. That's my practice. No risk factor, PSA less than 1 at 40, 42, you don't have to do it for probably 5 years. It's reasonable. I mean, things can change, but that's generally a good predictor. Mine was less than 1. I'm not doing it for 5 years. So.
Not the patients. They recommend you to do it.
No, you can do once a year, but I don't think doing, but the other thing we see is like patient coming and they come in, I'm like, so tell me more, and they open a book and there's a list of PSAs there. No, that's too much. I mean, that's absolutely not. And I have patients with biochemical recurrence, they're having PSA every 3 weeks. They look, it's pointless because so much variation, you can't read. Like, what does it even mean? So it's too much PSA is bad too. I don't think we should do it more than every 4 months. That's for bad cancer, and for everybody else once a year. I don't do more than that, unless there is a reason. Someone on treatment, etc., different, but for surveilling, it's probably definitely no point. It also stands for patient-specific anxiety.
Yeah.
So it does cause a lot of problems. Right, I don't do many of them.
Any other questions?
We have sometimes with these patients on anti-cancer, so their hormone levels are pretty low, bone health issues,
Yes.
and dental issue come to the picture, and the dentist says, no, don't give any anti-osteoporotic medication there. How to handle that? Because he's on prednisolone, he's on various medication, and this problem because of the dental person says he's a bit worried.
So there's a risk of osteonecrosis of the jaw. With
But
it's about 4%, but it's horrendous when it happens. So if we got, so Jane does a lot of our bone health. If I'm starting somebody on, I'll send them to the dentist, get them to write me a letter, say we've checked their dental health and it looks good. I do manage patients with castrate-resistant prostate cancer. They need to get the injection every month based on guidelines. And the guy is doing fine. He's 80, 70. I want to be proactive, protect his bone, but I don't want to kill him. So even if the risk is 5%, we make sure they usually write them a letter. They go see a dentist, and the dentist give a report back. If they have cavities, they'll treat them then before we give them every month. Otherwise, I won't do it. It's just too much at risk, Jane.
That's when you're looking at the, say, the bisphosphonus or the neurospec bone cancer, which is much higher than the osteoporosis. The osteoporosis risk and the ORNJ is much less. So when you're giving for bone cancer, high doses monthly, much higher risk of ORNJ than giving 6 monthly denosumab.
So so if they're on ADT every month, but if they're castrate resistant, the guidelines is every month. So for those one, I send them to the dentist.
Oh, correct, that's what I'm saying.
Yeah. So but the rest of them you give, and I just said perfect. I don't have to make that decision. Yeah, absolutely.
So if the dentist gives the clearance, you will give it.
Well, then I mean, this is I don't look in people's mouths, right? I go by what the dentist said, and if they are happy, generally the risk is lower. But if they have cavities and bad dental health, the risk is much higher. And we're giving once. I mean, it's a very difficult problem to treat if they get it. So we are very scared of it. I've never seen the person I treated, but it can be very bad. It can be very bad. Any major reconstruction, etc., is like not good.
Any other questions? I'd like to thank you, Homi, very much
pleasure,
for your talk to us on Dave. Thank you very much for telling us about survivorship care. And thank you very much for your time this evening. If you want to chat to any one of our presenters, feel free as you're leaving. Thank you.